gonna say, you're from the state rural health office. Yeah. Good. Oh! Excited to meet you finally. My hero, my nursing hero. And I like the fact that you're like the only nurse on so many nurses.
I did one.
Thank you for representing us so well. Okay. What would your objective be? Recruitment retention. Okay. Interesting. Okay. I will. Also, so tomorrow is the National Race, which is where all of the APRN stakeholders gather on the phone. But the National Council of State Boards of Nursing is always there. So let me tickle their ear and say, hey, what have you guys heard? And just see if they have any innovation. Yeah. And then I'll circle back with them. Yes. I saw that. This has not been a football season. Yeah, so we've just kind of been just want to get through the season and look forward to next year. So 7 states stabilization. Oh my! Out of the loop a bit. does that mean? Because I'm like, it's not my area of expertise. And so I selectively choose them because I know that we spend time with me and not just, oh, excuse me, I have to take this. Well, it's a Monday. Yes. So, no problem. No problem. It's all right.
Check, check. Check, check, check.
That's right. That's right.
Can I check it? So what we're doing is I'm gonna sit right back here, and what we're gonna do is I'm gonna bring them up in groups of 4, so there's not so much up and down. So these 4 will sit right here, and then you guys will be second 4 that will sit up here, and then there'll be one more group of 4 as far as presenting goes.
So we sit down until.
Yeah, you'll sit like right in these first few rows. So you're doing, I guess, she already helped you out.
Hey, Sam.
Hey, Dr. Ingrid. Yours is right here. I don't know, whichever you prefer. Somewhere where it's going to be easy for you guys to get up.
Yeah. I would think me on the corner and then Sandra, Daryl, Julie,
And then you'll,
yeah, thank you.
you want to look through all of them?
Yeah, that'd be great.
Don't you change it all. Yes, I think so. I'm double checking right now. I've got them all pulled up on the bottom. And I'm just going to sit right back here behind that curtain, and I'll just jump up in between and switch it for them so that we don't have any discontinuity probably.
If something goes awry,
Okay.
just look in the window back there and we'll come on.
Okay. Okay. Well, we'll cross our fingers not.
Yeah.
Don't need to fall off the stage.
That's
Don't
right.
need to pass
Hey,
out.
listen, we are so
Don't need
used
to
to
throw
rolling.
a fit. No
We
need-
That's
are.
right. That's right. So yeah, we should be good. And we got the clicker. The only caveat is the very last presenter. She's had knee surgery, so she's gonna be sitting over there, and she's just gonna. I'm gonna bring her the clicker. It should be, and she'll do it ramp up.
We need to put a mic on her.
So she can sit. It probably would be easier if we have one. Do we have a lapel? Okay. So as soon as she gets here, I'll
It's the
kind of.
last one. Who is it?
Denise Conway. She's the very last one.
Last one.
And
So
they asked
like
her to-
2 o'clock.
Probably. But as soon as she gets here, I'll.
We'll coordinate that during the
Yeah,
break,
that'd be
during the
great.
lunch break. All right?
I think I'll forward. And then go back down. So then you'll be like, yep. And then after that, then I'll do the other 4. I don't know. Here's
You know, like the APRN project, there it says, band or
we're gonna bring up like 4 first presenters all at one time. So we don't have to, you know, everybody can just talk about this. You'll be in that first group. And I'll be sitting right back there, so I'll load the presentation. You know, you don't have to worry about that.
So how are they going to advance?
You are going to advance, unless you request me to do so. But yeah, I've got a clicker, and the keyboard is right there as well. So if you need that, you can use that. Okay, perfect. Well, nice to meet you. I'm Corey, by the way.
The on-off switch is on the very top. It's a
Okay.
little tiny thing.
Okay, great. Thank you. I'm Catherine. Nice to meet you.
Check, check, check. 1, 2. Check, check.
Right.
Randy, where do you live? Okay. Okay, what's she doing? I know. And it's like you never know. Some people come to Augusta and a lot of people. Get me out of here. Well, I grew up. You did? Okay. Yeah. Oh no, me too. I did. And I left. And then I just came back about 3 years ago. And I left. Yeah. And it's changing, I'm sure.
I know.
my guess. Yeah. Probably the whole, all the APRNs candidates. That agenda just having all the recount into the, yep. That's how they want it. Short and sweet. That was way too short. Here at the shred, and then to advance this way. And if you accidentally, sometimes it's sensitive, so if you accidentally go, it does work. But I just tested it. It should be good. Good to see you. I appreciate you. Is it? It's a nursing home next door.
Guess everyone heard free Chick-fil-A and came on.
Yeah.
Okay, I think we're gonna go and get started. Good afternoon. I recognize a few familiar faces. For those of you that don't know me, my name is Arpita. I'm a Hemonc clinical pharmacist in the inpatient setting. If you already not worked with me, you probably will at some point this year. I primarily rotate on the BMT and acute leukemia service, and I think that you all have to start these two weeks, right? Yes. I'm gonna pick on you, so don't fall asleep on me.
Nice.
I was almost awake for 3 hours last
Had
night.
last.
Okay, so we're going to talk about onco-emergencies today. Primarily going to be focusing on tumor lysis syndrome or TLS, hypercalcemia, and then we're going to briefly talk about core compression and SVC syndrome. So how many of you have taken care of at least one patient that's had either one of them?
Breast didn't come, did they?
All right, that's 50% of the hands. Okay, the rest of you that already haven't, I'm sure you will at least once in your career here.
Good.
The other onco-emergency that I'm not discussing today is for neutropenia. You probably already had a lecture on that, or should have a lecture by ID group. Yes, no? Neutropenia. Yes. Okay, very good. It's another onco-emergency that I'm not discussing today because it's a separate lecture on its own of 1 hour.
Right reception.
Okay, so first let's talk about tumor lysis syndrome.
Yeah.
It
Yeah.
is a life-threatening emergency. And I repeat, this is a life-threatening emergency. TLS
Should have your
not
name
be
set
taken
up
lightly.
somewhere. I'm not sure which.
There's
You're
mortality
welcome.
reported up to 50% in patients where this is not adequately managed.
I
When
say.
you talk about TLS, screening for TLS or preventing and managing, there is no such thing as, oh, let's wait and see what happens. Either your patient has TLS or they don't have TLS, and you have to act very, very quickly. So this is a life-threatening emergency that happens from a rapid and massive lysis of malignant cells that ends up causing release of the intracellular components into the bloodstream. Incidence of up to 25% has been reported. And it's important to note that you can have spontaneous TLS too. You don't necessarily have to receive chemotherapy in order to get TLS. While the incidence of spontaneous TLS is very, very slow, you can have a patient with very high tumor burden and just have spontaneous TLS in the absence of actually getting chemotherapy. If patients are going to have TLS, happy early Halloween, I guess. I don't know. Okay. All right. It can be observed in up to 72 hours after starting chemotherapy. Okay, so here's the pathophysiology. If you all have some free time, which I know most of you don't, I really, really encourage you to go read this article. It's published in New England. It's about a decade old, but it's really, really well-written article. Anyway, so this talks about the pathophysiology of TLS. So as you can see on top, we have the lysis of the intracellular components. Hi.
Stepping and
Can you hear me out there? I just turn this off.
Actually, I called up for Townsend last week. Asked her to see if she could talk with you about
two heartbeats. The building there. All right. Let's get started today. And so I think they're probably free. I know that Chick-fil-A sandwich tastes mighty good. Y'all keep on eating. Just turn your cell phones off for me. We appreciate Augusta University having us here today. And we're delighted to have the State Senate Health Committee and our distinguished members that have been appointed to this committee. The members of the Study Committee on Barriers to Georgians' Access to Adequate Health Care. And I'm Senator Renee Unterman, and I drove down here from Gwinnett County, and I bet there's some folks in here from Gwinnett County. We're delighted to, oh, I see you are, yeah. I'm from Beaufort. Where are you from? Swanee, that's my district. I'm your senator. Don't forget that. Well, we're delighted to be able to be here, and this is our second committee meeting. And the Senate has been very, very busy, as has the House. And I think there's a House member here. Was a House member here.
Dr. Newton.
There you go. Dr. Newton. Representative Newton is here from Augusta, Georgia. Thank you for coming. We appreciate it. Let's introduce the committee first of all. But before that, Senator Walker, if we could have a short invocation, I would appreciate that.
Bow with me, please. Heavenly Father, thank you for this day. Thank you for this fine institution. Thank you for those gathered here that you have called to serve your fellow man and take care of our health care needs. Lead, guide us, and direct us in our deliberations today. Give us wisdom to make the right decisions that would be pleasing to you. All these things we ask in your precious and holy name. Amen.
Amen. So, Dr. Kinsel, we all know one another, but let's start down there and just introduce yourself and where you're from and why you're interested in this committee.
Thank you. I'm very interested in this committee. I'm Dr. Karen Kinsel. I'm a physician in Fort Gaines. That's in Clay County in southwest Georgia. In fact, I'm the only provider. I've been the only provider for 12 years. So if any of you all mid-level providers that want to graduate and come to a rural area and really serve the community, please come. And we hope Georgia will find more effective ways to take care of the rural areas.
Hello, I'm Dr. Patrick O'Neill, Commissioner of Public Health, and very happy to serve on this committee.
Good morning. I'm Larry Walker. I'm from Perry. I represent Senate District 20, which is Lawrence, Bleckley, Pulaski, and Houston counties. Glad to be with you today.
Hi, I'm Megan Andrews from the Senate Research Office. I staff the Senate Health and Human Services Committee with Senator Unterman, and I'll be staffing this committee as well.
Come on. Is this better? Yes. Okay. I'm Lucy Marion. I'm the dean here at the Augusta University College of Nursing. I have a family nurse practitioner background. I'm very privileged to lead the great faculty who prepare the APRNs of the future.
Good morning. My name is Joe Hood. I'm Deputy Commissioner at the Department of Community Health. I'm here on behalf of Commissioner Frank Berry. Very happy to be here. Thank you.
Hello, my name is Brenda Rowe, and I am a member of the Georgia Board of Nursing. We have over 162,000 licensees between LPNs and RN license in Georgia, and we regulate practice, education, discipline, and education. I'm not sure if I said them all. Discipline, practice, education, and licensure. And I am very interested in improving access to health care for all Georgians, and so very, very interested. And it is truly an honor to be a part of the study committee. Thank you.
Hello, my name is Erin Hernandez, and I'm the APRN representative for the Senate Study Committee. I am a pediatric nurse practitioner, acute and primary care trained. I have been working in the emergency room at Children's Healthcare of Atlanta at Scottish Rite for over 20 years, and also on faculty at Emory University.
Okay, I know Commissioner Berry was speaking today down in Columbus, Georgia, and I was supposed to be there too, and he called me and told me that he was going to be down there, and I told him that was absolutely fine since I couldn't go either. They're very much interested in our state health benefit plan and wanted to be able to have some questions answered for their annual convention. So with that, we're delighted to have all those nursing students together. I have to tell my nursing story. Everybody has a nursing story. I have many because I grew up at Grady Hospital. You can imagine how many I have. But I went to school at Georgia State University, and typical of Renee, if anybody knows me, they know me well. I have a lot of energy, and I used to get bored. And sometimes I would have classes at 8 o'clock in the morning, and then I wouldn't have a lab until 3 o'clock in the afternoon. And I graduated from nursing school. I'm a dinosaur, I admit it, in 1976. So I would walk up to the state capitol. And I had never been to the state capitol before, and when I was in nursing school, because I was waiting for that 3 o'clock lab that I had to go to. So I would walk up there and I would sit up in the gallery of the House of Representatives. And when I looked down on the folks that were sitting, the House members, 180 of them that were sitting down there, one of the things that stood out to me was that there was no women down there. Just a few women that were sprinkled in. You can imagine in 1976. And I learned a lot by sitting up there. You could barely see the people on the floor because of the smoke. There was a cloud of smoke, and you had to look through that smoke. It was like looking down from the clouds. The other thing that was very interesting to me since I was a nursing student was every desk had a spittoon. And there was quite a few that used that spittoon frequently and oftentimes missed it. But that kind of sparked my interest when I was in nursing school. I never in my wildest dreams ever thought that I would be sitting on that floor about 20 plus years later. But when you listen to the people today, you see intrinsically how politics, and a lot of people say I hate politics, and I can't say that I like politics very much either. But being an elected official, you can see how intrinsically law and what governs you in a profession is just as important as what you're learning here today with your clinical studies. Because it does no good to learn things and you can't be able to use those things that you learned in school. And also, we appreciate what you're doing and the fact that you're going into medicine and healthcare and becoming a part of the healthcare infrastructure in the state of Georgia. The number one thing we care about is the fact that you will hopefully stay and practice in the state of Georgia. That's what we want. We do have a dearth, a shortage of workforce in every field in medicine in the state of Georgia, and in particular in the rural areas. And that's what this study committee and the focus of it is. And if you pay attention, the purpose of a study committee is to develop the theory and the reasoning of why and use expert witnesses' testimony of what we do in January. We will start meeting in January of 2018 in session, and all the laws and bills that we're writing This is the foundation, and that's why it's so important. And that's why a lot of people drove from Atlanta to come here to see what we do, because they know this is the foundation of the laws that will be proposed in January, February, and March of next year. So we appreciate y'all and what you're doing. I hope you do well in school. I hope you finish school. And I hope a lot of you go on in school, because one of the things we need is upper level graduates to continue to go on to fill the shortages that we have. And we appreciate you and what you do. It doesn't matter if you're from the state of Georgia or not, if you came here from someplace else. We just appreciate what you do. And me being a background with a nurse and a social worker, I know how hard the profession is and the commitment and the professionalism that it takes. So we just appreciate you very much. So with that, we'll start out. Did I have anything else to bring up? We are on a short schedule. We have a full agenda. So we have allocated 15 minutes. And so for the committee's benefit, we're going to cut it to 12 minutes, and then the committee can ask questions for the folks that are testifying. And we do have one big panel. So when that panel comes up, if you'll just come on, sit up in the chair here, and then we'll have the panel, and then we can ask that panel questions. So with that, first on the agenda, and let me recognize today, this meeting is being recorded. Monday, October the 16th, and the meeting is supposed to be from 12 o'clock to 2:30 p.m. I'm sure we're going to go over a little bit to 3 o'clock, and we are in the Lee Auditorium. Thank you very much to Chick-fil-A and the administration of Augusta University and Margie Miller. Where's Margie? Okay. We appreciate Augusta University for helping us put this meeting together. So with that, we're going to hear from the Medical Association of Georgia, Dr. Scott Bolke. Did I say it correctly? You did. Good. Good. Thank you for coming. We appreciate it.
I was told to be right here, correct?
Yes.
All right.
That should be turned on.
I should be turned on. Thank you.
Yes.
I'm, as you mentioned, Dr. Scott Bolke. I am a family physician in a small town of Brooklet, Georgia, which is about 1,200 people. And some of these students may be from the Bullitt County, Statesboro area, and they may know it well. I graduated here, so some 30 years ago, so this auditorium was still here. I spent some time here, but it looks a lot better than it did when I was here. Did my residency in Columbus. I went to the Air Force for 4 years, and now I've been going on 19 years in Brooklet, Georgia as a family physician, solo physician. I have 2 nurse practitioners actually that work with me. I've been there, like I said, going on 19 years, and it is, and I think it's nice to see a physician in the rural area too as well here, and she would certainly agree. They're some of the most difficult patients to take care of because of the lack of resources, not only for them, but also the medical system itself. I am and the psychiatrist, I am the rheumatologist, I am those type of physicians who are not in the area and take care of these patients and do the best we can. And sometimes that's all you can do, is do the best you can for these patients. They desire and they need so much more, but we do the best we can, and I'm certainly she would agree with me that it's very, very difficult. These patients, plus probably the inner city patients, are probably the most difficult patients to take care of because of that, because of the lack of the resources that they have, as well as the medical system. So currently, I believe in a team concept. Once again, I do employ 2 nurse practitioners. They are vital to what I do in my office, but certainly I am overseeing what they're doing on an ongoing basis, on a regular basis, on a daily basis. I told you, in this town of Brooklet, the practice has been in existence since 1956. So 60 plus years to this practice. And when I got there, almost 19 years ago, all the records were on 5x7 index cards. So we've gone from 5x7 index cards to regular charts now to electronic medical records, which I've been on since 2003. So it's so much difficult to do what we're doing now with all prior approvals, with getting medicines approved, getting CT scans approved. It's a very, very difficult situation to get things done when you only have one place to go to get these things done. it's extremely difficult because of all the additional requirement that we do that has not direct patient care. It's all the, I call it the hassle factor. It's so much more that we have to do. I always bring up the point where I had actually had to get a prior approval on a drug that costs $4 at Walmart. And it's a point where you almost want to give up because that cost me a lot more in my staff time to actually do the $4 prescription if they just took it and paid cash at Walmart. So we certainly laud the committee, and I appreciate the time to speak to you. I'm not going to be very brief. I actually saw patients this morning and turned around and going right back and seeing them this afternoon. So we certainly hope that I sit on, by the way, I do sit on the physician workforce, which is now called the Georgia Healthcare Workforce. So I'm on that board, been on there for a year and a half or so, trying to do all we can to help the rural areas. So I've been actively involved in that, as well as the past president of the Medical Association of Georgia. So I learned from Dr. Bowler that was there that it was very active at the state level as well as the national level. So it is very near and dear to me because I learned from the best. So I will stop there and accept any questions.
Is there any questions? What do you feel like is the role? What do the nurse practitioners do for you in your office?
They help. I mean, indeed, help me take care of the patients. They are seeing follow-up patients for me. When they have questions, they come to me. So we have some very complex patients. When you have people, our older generation population, and certainly with obesity being as it is, I mean, we've got some very sick patients that come in our office. So they help me take care of them. They're getting things done outside the office, able to get those kind of things done, which is very, very important. As getting nutritionists, but we only have one nutritionist in the whole county, so it's very difficult to get patients seen by them. So they're able to assist us and do those kind of things too as well, which is very important because once again, we have limited resources.
What county is Brooklet in?
Bullock.
Bullock.
Mm-hmm.
Do they make rounds at the hospital with you?
No.
They don't. They're just office based.
Correct.
I say just office based. That's a big job in itself.
Correct.
What is the stance of the Medical Association of Georgia as far as the expansion of the APRNs in the state?
So we don't agree with the independent practice, but certainly we agree with the team practice, the team concept, which I think with all where healthcare is going with the ACOs and where payment models are going, we're going to the quality care versus quantity care. So I think this is just follows suit for that.
Mm-hmm. I had received some articles this weekend about the state of Oklahoma, and there was a senator there that was going to propose, I believe there, that APRNs are required to pay the supervising physician. You're probably familiar with this. And they were talking about one physician was paid $30,000 a year. And the purpose of the senator's bill was to negate the cost involved that seemed to be a hindrance in the rural areas, that the APRNs didn't feel like it was fair because there was very little supervision. What is your stance on that?
Stance on paying for that supervision?
Yeah, what do you think? Has the Medical Association taken in the House of Delegates, have they taken a vote on that? Or?
No, I believe we have not.
Is that because you don't agree with the expansion of the scope of practice, or you just haven't gotten that far?
I don't think we've gotten that far as what Oklahoma has done with the paying $30,000, but so no, we've not taken that up.
Has the House of Delegates taken a stance from the expansion of the scope of practice? Have they actually voted on it?
Once again, they've opposed it and are...
they voted on it?
I believe they, and Derek would probably, yes. Yes, we have.
They voted on it, that they're opposed to it?
Yes.
Well, if they're opposed to that, what is their solution to the primary care docs in the rural areas to be able to deliver services to more people? What is the changing healthcare infrastructure? What is their solution to it if they're opposed to the people that are practicing and learning how to do different things in the state? What's the solution?
Well, I think, I mean, we could go on for till 2:30, 3 o'clock if you wanted to on that answer, but it's very difficult. The solution is you pay the folks that are there, the physicians that are there, and hopefully with putting more physicians there and having their supervision with the nurse practitioners would be the solution. Once again, I sit on the physician, or now it's called the Healthcare Workforce Board, and that's what we're doing, and that's what we're shooting for. And matter of fact, I have a meeting here next week in the same, here in Augusta for that. But so I've always said I was once told if money's the answer, what's the question? It's about money. It's about paying folks to get them to do what they need to do out in the rural areas. It's, once again, when you're dealing with Medicare and Medicaid population, that's why some of these small rural hospitals are closing. They can't make it on just that type of payer mix. And in some of these counties, they don't have any other payer mix. So it's very difficult. I'm down to one exchange product in my county. And it's Blue Cross, and they may not be there next year come first of the year. So it makes it difficult for the patients too as well, because they have very high deductibles. So I work in a practice where I don't take appointments. I'm a walk-in clinic 5 days a week. I'm there until I see the last patient after 6 o'clock. So, I'm doing everything that I can to try to help access to care and take care of the folks. And I'm a lot cheaper than the emergency room, and I'm a lot cheaper than the urgent care. Okay? I don't think ER is the proper place to have their care. I think it's in a primary care office. And it's with a team, and it's a team with folks with all the same, goal and same desire to take care of these patients, which, once again, very, very difficult with their limited resources.
Do your nurse practitioners see patients when you're not in the office? Are they seeing patients now while you're here?
They do see some follow-ups, yes, ma'am. On a, just a small scale-down model.
Would they not see a new patient if they walked in the door?
Not typically, no.
And is there a reason for that?
Because with insurance and other things that we are required actually to see the patient initially, and then the nurse practitioners are able to see them moving forward.
When the workforce board is meeting, what is the solution to recruiting students to go into the practice of medicine now? Because when I talk to students, they don't want to go into medicine because they see the changing to the single payer system, and they accumulate $300,000 in debt, and they get paid $140,000 when they get out.
Right.
What is the workforce looking at as a mechanism to attract them?
One thing really, and actually Mercer and Dr. Sumner, who's actually a former nurse practitioner, now actually a physician, and now dean of the School of Medicine at Mercer, are doing something which they are actually nominating students as they go into medical school and fast-tracking them and actually getting them a residency all aligned before they even go through the match, which is, once again, at the end of the third year of medical school, or right before they graduate in the fourth year. So they're already lining them up, getting them through a little bit quicker, getting them into a residency that's more designed for rural health care, and producing those kind of physicians to get them out there with substantially reduced debt, which is outstanding. I just read where here at MCG, or I was at a meeting last week, and it's $28,000 a year here at MCG, and that's probably the most inexpensive one here in the whole state. When I attended, it was $3,600, and it's dramatically gone up. So helping them with the loan repayments, loan forgiveness, the Georgia Healthcare Workforce is able to give grants to these folks with a commitment of 3 years of service in that area. And what we've done actually is started going around and inspecting these practices to make sure that these physicians are doing what they're supposed to be doing, which is working in these areas.
Has the Medical Association taken a stance on the preceptorship? There was a bill last year about preceptorships. About
giving loan forgiveness a tax break for preceptorship. We were in favor of that. It was not hotly debated.
Okay. All right, we're just about finished with the time. Is there any other questions? Did anyone have any questions? Any other questions? Thank you very much.
Thank you.
Wait. I think Doctor has a question.
As you were talking, I apologize. I was kind of struck by your statement that younger doctors don't want single payer. My experience is, and I just looked up a survey, we're only down to, 19% oppose single payer. I think under a single payer system, people wouldn't come out with $200,000 and $300,000 of loans. It's the difference in the integrated system.
Thank you. We appreciate you coming.
I was going to ask one question, if I could.
Okay. One more question.
First of all, I wanted to thank you for your service to the community. I was raised in Scotland, Georgia, in Telfair County,
Yes.
and I know exactly about those 3x5 cards all those years. But there's a lot of evidence that APRNs can do a lot more. They can see new patients, and I mean it's a preponderance of evidence. I'm just wondering, is the Medical Association of Georgia looking at the data as they're making, as you have these discussions? Do you have some indication that it needs to stay the way it is in the state of Georgia?
Well, we certainly look at all the information and certainly understand those some studies. But I keep coming back to, when you mention the rural area, these are very difficult patients. I mean, they are, and they're difficult for me. And I've been doing this for 24, 25 years. And I can't imagine, a newly trained anybody, whether it be a physician or a nurse practitioner, taking care of some of the things that I take care of in my office and try to avoid actually them going into the hospital. And that's one of my biggest rewards, I think, for the patients, is keeping them out of the hospital. That means I haven't done my job probably as good as I should have. The patient's not doing their job. So it's a very difficult. And these patients are very complex. And we're certainly with patient safety, the whole adage, first do no harm. We don't want to, we want the best care for these patients. And I think a team approach is certainly the best way to do it.
What hospital do you refer to?
East Georgia Regional, which is in Statesboro. Mm-hmm.
How's it doing? How's the hospital doing? Do you know?
Hospital's doing well, just been bought out by CHS, so it's a for-profit hospital and very expensive.
Okay, thank you.
Mm-hmm.
Safe travels home. Okay, next is primary care shortage and APRNs. J.R. Richards, Chief Executive Officer of the Medical Associates Plus. I saw your building on the way in.
Oh, great.
FQHC. And Patsy Whaley, Executive Director of Georgia State Office of Rural Health.
Good morning. Greetings from Medical Associates Plus to all the distinguished guests. My name is J.R. Richards, and I am the CEO of the Medical Associates Plus. We are a federally qualified health center. Can we go? Not that one. Oh, okay, so. Oh, okay. Well, we have some technical difficulties, I believe. So on the screen behind you are the slides that I'm going to present. And again, we're Medical Associates Plus. We are a federally qualified health center. This is our main campus. Our mission statement is to provide quality and affordable primary health care to residents of Greater Augusta and the surrounding areas.
Let me just ask, are y'all going to get a test over this? If you are, you need to come down here so you can see them. Can you see them? You can't see the slides up here? Y'all want to move down here? We got plenty of room down here. You want to move down here?
Turn on the...
So,
It's not. Is the projector not working? Try it. Try it. I don't want them to fail their test. Yeah, try it.
So I have a 30-minute slide to do in 12 minutes.
Yes.
So we need the technical support.
That's okay. We're used to it.
So we were established in 1998 by the CSRA partnership to provide health care services to the low income and children of the CSRA. In 2007, we received FQHC funding under the 330E Public Health Services Act. So we're governed by Health Resources and Services Administration. They heavily audit us every year, every 2-3 years before our project period ends. Some FQHCs even indulged in the OIG audits. There are about 1,400 FQHCs nationally, operating 10,500 sites, and we're home to over 25 million patients. There are approximately 36 FQHCs in the state of Georgia, operating about 200 sites and serving almost 500,000 patients currently. We have to be located in high-need areas, so there are health professional shortage areas, medical underserved areas or populations, and these two designations we must have in order to receive federal funding from the Health Resources and Services Administration. So we provide comprehensive health care. We are open to all residents. We have to see patients regardless of their ability to pay. So we put patients on a sliding fee scale based on their income and family size. Many of the patients do have the ability to pay based on whether they're working or not, and sometimes even they refuse to pay. So we get patients who bill up bills up in the thousands of dollars, and we still have to continue to see them. That's a federal mandate. 70% of the health centers in the nation are recognized by national accrediting organizations as patient-centered medical homes. This is an advanced model of team-based care focusing on quality care and coordination. And we have achieved the highest recognition, which is level 3, at all of our primary care sites. The benefits of FQHCs for both practitioners as well as patients is that, again, we operate on a sliding fee scale. We receive the state's 1115 waiver of the Social Security Act. What that does is that gives us our reimbursements are higher than the average provider based on the fact that we see so many uninsured and underserved patients. We utilize the 340B pharmacy discount drug pricing program, which is a program that allows us to buy and purchase medications at federal discount prices and then turn that discount over to the patient. So many of our patients can receive medications for as minimum as $3. The National Health Service Corp is a program operated by the federal government, and that's a loan repayment program for providers. One of the questions you had, Senator Unterman, was what benefits are there to entice providers to come and work in rural areas? This is one of them, the loan repayment program. I also know that the state also does a loan repayment for the APRNs as well to entice to work in the rural and underserved areas. We operate under the Federal Torts Claim Act, so we cannot be sued directly. All malpractice claims goes to the federal government. That is another benefit for providers coming and working for FQHCs, is that you don't have to worry about malpractice insurance. These are our sites. Our main site in the left corner, our Medical Associates site in Rennes, which is in Jefferson County. The white building is in Keysville, which is in Burke County, serving the rural areas. We also have an infectious disease practice that's also doing infusion therapy over on Walton Way. One of them is missing. It looks like that's our mobile bus. We have a healthcare bus, 39-foot bus that goes out into the community and provide health care to those who lack access due to transportation barriers. And then the 3623 is a pulmonology site that we have located on the grounds of Doctors Hospital. Oh, there you go. This is the medical bus. We provide dental as well as primary care. On this van, we're going out to the local schools and providing dental care, in particularly for the children. These are some of the services we provide. I highlighted telemedicine because this is one of the services, the new inventions, and we just started doing telemedicine via the mobile van as well as the primary care sites. We started the substance abuse program, which is medication-assisted treatment for those people abusing opioids. That was a grant that we received from the federal government to address the opioid epidemic. And we're doing that in collaboration with Serenity Behavioral Health Systems, and we're doing that telemedicine as well. Infusion therapy and infectious disease I already spoke of. These I'm going to just skip through. This is our population. We serve 67% African American, 32% white, which is typical of the Richmond County demographics as well. This is not. We serve 30% of our patients are uninsured compared to the national FQHC rate of 23%. As you can see, 50% of on the national level are Medicaid patients and FQHCs, where we are 20% in our facility. Growth trend, this is a growth that we've encountered over the last few years. From 2014, we grew 78% with patients, 75% in our visits, and staffing 158%. We're currently at about 135 or so staff members. This, of course, is indicative of FQHCs across the nation, as well as in every community where hypertension and diabetes lead the major diagnoses, as well as obesities. And we're 47% hypertension, whereas the national average is 26%. So we had a great disparity there. Barriers to access, primary care and specialty care physicians provider shortage. Although the ratio of physician to APRNs agreement is 8-to-1, the APRNs can only practice at a 4-to-1 ratio at a time. And these regulations are under the physicians board and not necessarily under the APRN's board of regulations. It's also illegal for APRNs to hire physicians to enter into nurse protocol agreements. So this is also reflective of a barrier. ARNPs also cannot prescribe Schedule II drugs and often have to wait for a physician to co-sign if that drug doses need to be changed. We cannot order, APRNs cannot order MRIs or any other advanced radiological tests except in life-threatening conditions, and you're not accepted by many of the payer panels. So we often have to have physicians signing off on the ARP, and I'm not sure why they continue to call you all mid-levels. There's nothing mid about what you do. And I know this is, we do have some doctors in here, so I'm going to apologize now, but in my situation, what I find is that we can very well get 3,600 to 3,800 visits from a APRN on an annual basis, and maybe 4,200 from the physician. So what happens is, for half the cost of a physician, I can get almost as much visits by using an APRN. Some of the other barriers are financial, which is due to poverty. Co-pays are an issue for patients. That, in turn, causes a barrier with medication compliance because they can't afford the medications. So there are either no insurance or inadequate insurance. Those are the underserved who have insurance, but they do not cover many of the procedures. There's transportation barriers, as you know. Many people in the rural communities are still using golf carts to get around. Some of them have to depend on friends to bring them into the center, and when they do that, that results in high no-show rates because friends can't always come through at the time that they say that they might. The lack of faculty, the funding and clinical placements for students at universities is also a barrier. And these are the results of these barriers, where we have increased patient wait time, increased costs due to waste, decreased patient satisfaction, the financial burdens on individuals and families, delayed life-saving care, the inability to obtain preventive care, preventable hospitalizations and increased ER visits, unmet healthcare needs on a whole. And what happens to the uninsured is that they will not receive care, or they'll get poorer health, they'll have poorer health statuses as a result of not receiving that care. Many times they're diagnosed late and eventually die prematurely of preventive illnesses such as hypertension and diabetes. Some of these partnerships I'm not going to talk about because I understand that others here today are going to be touching bases on them. But how we are addressing some of these barriers is in collaboration with the College of Nursing. We participate in the Rural Health Immersion with Primary Care Partnerships for APRN Academic and Clinical Training, the IMPACT. That's pretty long. and basically it's student rotation and preceptorships at our facility. So they get trained with the best. One advantage to the APRNs being trained at our facilities is that you get to see the sickest of the sick, the poorest of the poor. And so many of these patients come with 25, 30 bottles of medications. And so a skilled APRN can provide 3,800 visits seeing these types of patients, which is very impressive to me. So we also partner with the College of Allied Health and Department of Physician Assistants, where we are rotating students and preceptorships through the Applied Learning Experience Program. We're also rotating students through our pediatric department with the Department of Pediatric Residency. The Dental School of College of Georgia also rotates students through our dental program. We have a dental operatory with 6 chairs. We're also involved in the rotation, most recent that we're going to hear about a little later is the behavioral health rotations as well, that we're going to be doing pretty shortly with the School of Behavioral Health. Some of our collaborative partners is the Augusta Healthcare Network. How much time do I have left? I'm sorry.
Let's talk about the financial cliff. I think that's the most important.
The funding cliff?
Yes.
The funding cliff currently, did I go too fast? So the National Health Service Corps, as well as health center funding, is in jeopardy as we speak. The funding cliff was ended on October 1st, and Congress did not appropriate funds for continued funding for FQHCs as well as the National Health Service Corps program. That's going to result in a 70% cut in all FQHC's funding. So we need bipartisan support to co-sponsor the two bills, Senate Bill 1899 and the House Bill 3770. That extends and reauthorizes the federal funding for another 5 years so that we can continue to do these collaborations with the university and serve the patients who are the most vulnerable populations of our nation. I'm going to end that there. I had some conclusions, which is and recommendations, which is to focus on monitoring systems of care, including workforce shortage, increase funding to support the needed faculty and placement of students, legislation to give APRNs the authority to practice within their scope, prescribe and schedule 2 drugs, leverage in entering agreements and extending the amount of APRNs that can practice at a given time, address issues of insurance and other barriers like transportation, provide additional incentives for providers to work in rural communities, increase the use of telemedicine to deliver care, integrate behavioral health and oral health into the primary care system. This is another initiative that we are doing as well, and support fixing of the FQHC funding cliff, as well as to continue the state funding for the loan repayment for the APRNs. That concludes my presentation. Thank you for listening, and I'll take any questions you might have at this time.
Thank you. Are there any questions? Any question? No question.
Oh, that's usually a good sign.
Wait a minute. Senator
Thank you.
Walker has a question.
Who determines where FQHCs are located? The federal government or the state or?
The federal government, HRSA determines that, but it's based on those designations, whether the area is a health professional shortage area, a medically underserved area, or has a medically underserved population. Then they have other designations such as mental health shortage area, dental health shortage area. So if you're not in one of those areas, you would not receive the funding. But the federal government determines based on the mapping of those areas if the services are needed.
And if I could ask another one, the Medical Associates Plus, I assume, is a nonprofit organization.
Yes, we are.
That receives this funding from, you're not a federal agency or a federal employee yourself, are you?
We are considered federal employees only because we receive federal funding and we are regulated by Health Resources and Services Administration. But we're not entitled to the benefits of the federal employees, if that makes sense.
No, it doesn't.
Yeah.
I'm so impressed with your organization, with your presentation. Thank you. And for those of us who are not really familiar, I mean, basically FQHCs is kind of like having Medicaid expansion in these underserved areas. And generally it works out pretty well. I mean, you attempt to provide more intensive care than even what expanding insurance would do. Sometimes there are glitches where the sliding fee scale where people can actually enter access into the system is an issue. As you know, the HRSA regulations say that for patients under the poverty level, it should be free or nominal.
Right.
And sometimes the co-pays at the FQHCs are a barrier.
Yes, co-pays are a barrier. That was one of the financial barriers that I pointed out to. But what we're able to do with the discounts from the federal government for the medications, we're able to take that money and put it back into services. So when we find patients who are in dire need of paying copay, we might take that payment on for them. As well, our sliding fee slides down, so a $200 visit, patients can come for $30. So it's a pretty significant slide, but we don't turn people away. So even if they don't pay that balance, the balance just builds up. We write it off as bad debt. We write off probably about $1.5 million a year in bad debt, uncollectible debt.
Thank you.
Serving those patients who are uninsured.
Any other question? Yeah, one question.
I was wondering, do you know what's the possibility for expansion of FQHCs in Georgia? You talked about what qualifies. I was wondering how many areas qualify that don't have them, or do you have an estimate of that?
Not off the top of my head, but the Georgia Primary Care Association, they gather those statistics and conduct those kind of needs assessments to show where the areas are of most need. And so we're looking to expand. Again, we're in 3 different counties here in this area. So we're also looking to expand into Lincolnton, providing that those dollars become available through Congress for new start applications. Okay. Thank you.
Thank you. Ms. Whaley?
Forward. Thank you. Senator Unterman, members of the committee, thank you so much for inviting us today. The Georgia Rural Hospital Association presentation to the Senate committee. We're going to talk a little bit about rural hospital stabilization. The mission of the Department of Community Health, of course, is to provide access to affordable, quality health care to Georgians through planning, purchasing, and oversight. The Rural Hospital Stabilization Committee, the hub and spoke model, the right care at the right time in the right setting. The hub and spoke model includes the hospital, which is the hub, with FQHCs, boards of education, critical access hospitals, public health, physicians, local industry, tertiary hospitals, nursing homes, EMS, home health, behavioral health, and technical schools as the hubs, as the spokes. Just a little bit of history about the Rural Hospital Stabilization Program. It was established in 2014 by Governor Deal because of the rash of hospital closures. In 2015, the hub and spoke model was chosen because it was determined to provide the most value to rural communities. $3 million was appropriated. 4 pilot hospitals were identified by the legislature. $750,000 in grant was awarded to each hospital. Those projects were chosen and initiated. And by the way, they have all closed. In 2016, $3 million was again appropriated Phase 2 hospitals were chosen. 4 were chosen, 1 opted out. The remaining hospitals were awarded $3 million in funding. Those projects were chosen and initiated. In 2017, $3 million was appropriated. 12 hospitals were chosen for the Phase 3 program. 1 has opted out. $250,000 awarded to each hospital. Education and training has been initiating and is continuing. Those projects are under development as we speak. This is a map of the Rural Hospital Stabilization sites. The pilot sites in yellow: Appling, Crisp, Emmanuel, and Union. Year 2 in green: Habersham, Miller, and Union. Year 3: Bacon, Chateaugue, Cook, Effingham, Irwin, Jasper, Liberty, Memorial Hospital and Manor, and Bainbridge. Mitchell County Hospital, South Georgia Medical Center, Lanier Campus, and Washington County Regional Medical Center. Some of the projects for the stabilization phases 1 and 2, EMS and emergency department connectivity, school-based telemedicine, occupational health, level 4 trauma designation, chest pain center designation, school, on-site school clinic, reduction in readmissions within 30 days, remote stroke center designation, community paramedicine, telenephrology, care coordination, behavioral health, housing to accommodate medical residents, and reduction in non-emergency utilization of the emergency department and EMS. Rural Hospital Stabilization and APRNs in the pilot program, we used utilization of an APRN and occupational health was planned. That did not occur. The APRN was replaced with a PA. Also, one hospital planned to use an APRN in their nursing facility to provide additional improvement in outcomes for residents and reduction in preventable hospital readmissions. This was not supported by the medical director. Phase 2, extended hours clinic, employ 2 APRNs. 1 would be funded by the grant and 1 by the hospital. The results of this program from June to August of this year was a reduction in ED visits of 800, increase in clinic visits 1,124 over the same period in 2016. Also planned for a Jerry Psych project, hiring a Psych APRN. At this time, with programs and projects under development, we are not certain how APRNs are going to be used in those programs. Challenges that have been experienced with rural hospital stabilization: community education, physician engagement, timely data, and connectivity. I'm not going to read through, but I thought you all might like to see some of the comments that some of the hospitals made. These are comments from the Phase 1 pilot group. We would like to extend an invitation for you all to come to the Rural Hospital Stabilization Committee meeting. That is scheduled for Thursday, November 2nd at the Georgia Public Safety Training Center in Forsyth. The agenda for this meeting will be Phase 1 outcomes, Phase 2 progress, and introduction of the Phase 3 hospitals. And any questions or additional information, you can certainly contact me or our project manager for Rural Hospital Stabilization, Lisa Carhub, who is also our Director of Hospital Services. I'll answer any questions that you might have.
Questions? Commissioner?
Swaley, I'm the State Medical Director for EMS, so I'm very interested in utilization of medics as a community activist, mobile integrated healthcare, or community paramedicine. Has there been an evaluation of the program that occurred? And if so, what was the outcome?
We have not evaluated the program specifically as a project. Currently, over time, with some of the projects that we have done regarding EMS, not only with rural stabilization, but with other projects, EMS projects through the state office, we have noticed a lot more interest in communities as well as paramedicine, paramedics and EMTs to embrace the community paramedicine program. We have done a work study evaluation that is available for review, but not an evaluation specifically of community paramedicine.
And what county or counties did you have the program in?
Pretty much across all rural counties. The workforce study, of course, included all rural counties, as well as the urban and metropolitan areas. A couple of our projects were network projects that included one or two or three counties that work together on an EMS community paramedicine program along with the local hospital. That was in Cook County and surrounding areas. We've also done a regionalization study, which has included EMS across rural Georgia. Some interest in that in some areas of the state, primarily right now in the western part and southwestern part of the state. So a great deal of work with EMS. One of the issues that has always come up has been, it's a good idea, mobile integrated health care or community paramedicine, but how are we going to get paid? We are currently working with Medicaid on a couple of projects, one to include treat but no transport when a patient is treated but refuses transport to a facility. We're also looking at transport to alternate destinations where that patient may not need to go to the hospital emergency room, but could maybe go to the FQHC. And we're also looking at payment for community paramedicine.
Thank you.
Any other questions? No other questions. Thank you.
Thank you.
What time does that meeting start?
It starts at 10.
10 a.m.?
Adjourns at 2.
Okay, 10 to 2. Thank you. Right, next is Dr. Elizabeth Downs. Then if the next group could go ahead and come on up, which is Sandra Inglett, Daryl Thompson, Julie Zadinsky, and Bethany Smith, and those are all doctors. You got enough chairs over there? I can't see. Yeah. Okay. Thank you.
Thank you. Good afternoon. I apologize. I have a bit of a cold. My name is Elizabeth Downs. I'm head of the master's program, MSN program at Emory University. This is First Lieutenant Dorothy Downs. My mom was a nurse in the Army in World War II.
Now, I didn't look like that. She's much more attractive.
Aww. She graduated, excuse me, she graduated from the university, excuse me, she graduated with her diploma in nursing from Buffalo General Hospital. She had, the hat, the hose, the white uniform, the white shoes. She did not have a stethoscope. In her practice, only physicians needed stethoscopes because only physicians took blood pressures when she was a nurse. She certainly never listened to heart sounds or lung sounds. Her career spanned the discovery of both penicillin and DNA. And I can remember her sitting at the kitchen table. I have some, thank you. I can remember her sitting at the kitchen table learning about DNA for the very first time with my older sister, Mary, who herself became a nurse when she grew up. She got an associate degree and then a bachelor's degree and worked in a rural hospital. She married Dan, who is a certified nursing assistant, And why am I showing you all these pictures of my family story in nursing? We have seen a tremendous change in nursing education. The education my mother got would be inadequate for healthcare today. My sister Mary, with 2 nursing degrees, recognized that when she was having to manage change and systems in a rural hospital, she didn't have the skills to do that. And so she went back and got a master's of science in nursing. And Dan, who just retired, will tell you that he has seen a tremendous change in his own career as a nurse anesthetist. They have moved to doctorate of nursing practice entry. Most professions have some layers of preparation. So there's a medical assistant, physician's assistant, medical doctor, a nursing assistant, a registered nurse, advanced practice nurse, and dentistry with dental assistant, dental hygiene, and dentistry. This quote talks about what happens for change to occur. Situations in healthcare change because of the people who are providing the day-to-day patient care activities, coupled with visionary leaders who ask themselves important yet simple questions. How can what we do be more effective, more efficient, and safer? This is a quote by Paul Abramowitz, who was speaking of the evolution and metamorphosis of the pharmacy education to a PharmD. So our colleagues have already moved from a bachelor's level education or a master's level to a doctoral level, so a PharmD and a physical therapy doctorate. This evolution and metamorphosis is also true within nursing. The MSN prepared APRNs receive quality education, the standardized curricula, and clinical practica that assures they'll complete their program with nationally accepted standards, and they'll be ready to be credentialed as certified nurse practitioners. Now, full disclosure, I'm head of the master's program at Emory, and I teach master's prepared nurses, not doctorally prepared nurses. But I do see a need for an additional role. Our master's takes 50 credits, nearly 50 credits to complete, 50 college-level credits to get a master's. When you start looking at the need for management of increasingly complex patients, systems change within hospitals, the financial management components, these require additional competencies. And as you start packing in the credits, you're now looking at what is essentially another level of education to get that advanced educational credential. Let me give you an example of what the 2 different roles might do. So I have a friend who's a nurse practitioner in a liver transplant unit. Now, these are obviously very ill patients, and she recognizes that the medications they need to take every day are life-sustaining. She's a well-educated, well-prepared, well-respected member of the team, and she's concerned when patients come back with non-adherence, not being able to manage to take all these medications. The 50-some-odd credits she may have gotten to get this to be a well-prepared master's nurse, advanced practice nurse. And she's asking the question, well, why aren't they taking their medications? What can I do to improve patient adherence? So her team in the hospital recognizes that this may take more preparation and supports her to go back and do a doctorate in nursing practice, where she learns the skills and gets the competencies to do motivational interviewing as part of a team, both on the unit and in the clinic, to improve patient adherence. Another example might be a clinical nurse specialist who works in the emergency department. She manages the unit well, she assures that all of her staff is competent, and she occasionally steps in and works as a staff nurse, as is required. She does an excellent job, and in fact, she's an exemplary leader and is asked to move on up to organizational management. And she recognizes while she has the competency to do unit management, perhaps she doesn't have what it takes to manage a big unit, to do systems change management, organizational management. Those are other skills. So at this point, does she get an MBA? Or is there a specific content area, such as that in a doctorate in nursing practice, that would give her those skills to be able to do systems change management? Nurses with practice doctorates are needed to do more than direct patient care. They deliver care, but they also work in health policy, they evaluate the evidence, they set standards and really ask the questions and solve some dilemmas in healthcare. Establishing a doctorate in nursing practice, while it may not be all that's needed to get for direct patient care skills, it would give us parity with our colleagues, such as pharmacists and physical therapists. But additionally, it gives the nurse practitioner or the clinical nurse specialist or the nurse anesthetist or the nurse midwife the additional competencies to manage in increasingly complex patient scenarios and in a health system that is constantly changing. So I thank you for your time today, and I'll answer any questions that you might have.
Questions? Won't you get better?
Thank you very much.
Thank you. We appreciate it.
If I could...
Go ahead, Dean. Go ahead.
Thank you very much for your presentation. I think you did a really eloquent job of explaining this transition. And as I'm watching all of our schools, we're making this transition, some faster than others, and throughout our university system of Georgia as well. I'm just wondering, what are the barriers to making this transition in the state now from the APRN to the DNP that you see?
I think there are numerous. There are things like systems change within universities themselves. Who makes the decision for nurses to be able to offer doctoral degrees? Is it within the School of Nursing? Is it within the university? Is it within the UGA system? Who grants the graduate degree? So that in and of itself can be a very complex level of decision-making and change. I would say that there's some resistance to the role of the nurse as a doctorally prepared nurse. I think that master's prepared nurse practitioners do deliver excellent quality care. And I don't think there's an understanding of the difference and the level that a doctorally prepared nurse practitioner can bring to the mix. And I gave some examples. For example, how do you work with individual patients, or how do you do systems change? They're qualified to do more complex levels of care as well as management change.
So could you share with us like the number of how the increase in clinical hours have been occurring?
Right. For a master's prepared nurse, you need that standard 500 hours of clinical practice hours. Most of the graduates get far more than that. In fact, many of our graduates complete over 1,000 hours. The nurse practitioner, the doctoral level nurse practitioner, needs additional hours to focus their quality of education and to use that knowledge and skills, become adept at using it. So even if you have over 1,000 hours of practice as a nurse in a master's level education, you still need more hours to learn to use those skills at the doctoral level. So every program will have in-house hours, minimally 200, usually more closer to 500 additional hours.
Thank you.
Thank you. Any other questions? Thank you.
Thank you. Next, we've got a panel, and this panel is College of Nursing faculty and how to prepare nurses for rural health. Before they come up, I want to introduce Representative Gloria Frazier. Are you here? There she is, right there. Stand up. Representative Frazier represents District 126, which is the Augusta area and Burke County. Is that correct? And she and I have worked on many bills together, specifically sex trafficking and all the laws that we've changed and the appropriated money. We appreciate the BFF coming to town for us. Thank you.
Thank you, Senator Unterman. Welcome again to Augusta University, and thank you for the time on this panel discussion. I am Dr. Beth Neesmith. I'm chair of the Department of Physiological and Technological Nursing, and our College of Nursing is the flagship university in the University System of Georgia. We have campuses in Augusta and Athens, and we also have a presence on the Columbus State University campus. We have 4 degree granting and 4 advanced practice certifications programs. We have 863 students. 497 of those are graduate students, and 367 are undergraduate students. And this year, we'll have the pleasure of celebrating our 75th anniversary. Wow. We are very excited about that. We started in 1943, and we invite you guys to join us in March for that celebratory event. So we have 6 signature projects in the College of Nursing. We have East Central Regional Hospital, where we provide and manage behavioral health care for our community individuals. We have our Healthy Grandparents Program, where we help support and educate grandparents who are providing care to their grandchildren. We assist and lead the Costa Lehman Health Fair, where together with our alumnus, Dr. Debbie Lehman, we provide care for underserved migrant farm workers in the community where they work. We have the Greater Augusta Healthcare Network, part of which is led by Dean Marion, and we had Mr. Richards, who participates in that, talk with us earlier. And we lead the Cervicusco Peru Study Abroad, where nurses, students, and faculty literally climb mountains to provide care for Peruvian natives. And we have our Healthy Start initiative. So today, very briefly, we will talk about our rural and underserved outreach programs. On the agenda are 5 programs. We'll talk about the Community Healthy Start, HRSA-funded service. Dr. Sandra Inglett, who is trained as a neonatal nurse in the intensive care unit, we'll talk to you about that. And we have our IMPACT program, which is also another HRSA-funded training program. Dr. Daryl Thompson will talk to you about that. He's a family nurse practitioner and an acute care nurse practitioner. He'll also talk to you about a recently funded behavioral health initiative funded by HRSA. And we'll also talk about rural access to care. Dr. Julie Zadinsky will talk about that. She is, by training, a pediatric nurse practitioner and a PhD nurse who has conducted research. And then I will talk to you lastly about our nurse practitioners as emergency providers in rural healthcare settings, a proposed training initiative that we will talk about. So first, I'll invite Dr. Sandra Inglett to the stage, and if it pleases the panel, in the interest of time, we'll hold our questions till the end.
Thank you, Dr. Neesmith. As Dr. Neesmith mentioned, I am the project officer or director for Enterprise Community Healthy Start. It is a HRSA-funded service grant funded every 5 years. This particular round of funding was 2014 to 2019. We are up for a new round in about 14 months. HRSA's primary goal for this was to reduce infant mortality rates and low birth weight babies in rural and urban counties. My grant specifically has a catchment area of Burke and McDuffie County, both rural, both underserved areas. We case manage approximately 450 high-risk women and children in our program, and we've been a very stable program in both those counties for almost 20 years. We began in 1999, so we're very proud of that accomplishment. Healthy Start, over time, has seen a change in healthcare, just as everyone prior to me has mentioned, and one of the challenges that we face frequently is the lack of acceptable and affordable health care. Burke County's OB department closed in their health hospital. McDuffie County does not do delivery services. They have very limited specialty services. They have to all travel to Augusta for that. They are typically seen by family practice groups and then transferred to down here in Augusta for their final month of care and deliver somewhere either here or at one of the other local hospitals. The federally qualified health centers, there are none in McDuffie County. There is Keysville in Burke County, but they don't do delivery services and they don't do high-risk OB care. So, that's an opportunity for Mr. Richardson down there to look into, because we would certainly love to have additional services available to us in those counties. The other things that we have seen are the increase in risk factors in our OB patients. We're seeing later and later entry into care. We are seeing more risk factors. Instead of maybe just having one, they'll have 3 to 5. Our average client has a minimum of 3 high risk factors, that being depression, obesity, either chronic blood pressure or potentially asthma, but they typically have 4 high-risk factors in their care, service, and delivery. Now, while we, as a program, don't do specific health care, we can link our clients up to services that are available either in the county or here in Augusta. And there's not a lot of services available in those rural counties for high-risk moms and those that are suffering from chronic problems in OB. There are several social determinants of health that play into this. There's a lack of income, transportation, there's inadequate education, low health literacy, which is not to be confused with literacy, because you can have someone with a PhD who has low health literacy, but it's understanding medical jargon, understanding the systems, and so that plays a part in our healthcare delivery as well. And a lot of our clients had trouble navigating and accessing insurance and Medicaid websites. Those websites are difficult for even myself sometimes to figure out where to go and how to access those websites. So I know it's a problem for our older population in the counties. And our women, what we find with the ladies in our counties who are pregnant is they're not sure who to go to for what. And that's one of the things that our program is very good at, helping them figure out who to go to, when and where and how. And my case managers are no longer all RNs. We used to have an all RN staff, but we no longer have that because of funding cuts, just like everybody else. But I do have highly trained community health workers, and they've been through quite an extensive orientation, and they understand the process of how to refer, where to refer, and when to refer. So those are some of the challenges that we face in the rural counties. And transportation may sound like not a big thing, but it's much easier to get someone to transfer you or to take you to town, so to speak, rather than to drive you 45 minutes or an hour to Augusta to see a physician and then have to sit while you wait for your appointment and then drive you back home. Whereas they can scoot you up to town in 10 minutes and then go about their business and come back in a couple hours and pick you up. So transportation is a very big deal in those rural areas. So for us, there are opportunities, and we've been able to identify some opportunities. One is to be able to improve the county health rankings. You probably have heard of those. And Burke County ranks 141 out of 159, and McDuffie ranks at 112 out of 159. We could have some increased focus on preventive care, more access in the health departments, more programs available, lots of opportunity in the rural community for advanced practice nurses or clinics to help bring in more of our moms and our children. Now, the strategies that could improve that would be expanding, of course, and increasing those APN practices within the local health departments. Burke County's health department doesn't have an APRN. McDuffie County does. It just depends on how the local hospital board sets up the county health department as to what range of employees they have. Preparing those APRNs for telemethods of delivery. Within our program, like I said, mental health and depression as well as the OB services are definitely needed. And we could do some mental health counseling through telehealth and telemedicine. And there are models that are available and out there, but again, it all kind of falls back onto funding opportunities. And we could design some more innovative pregnancy programs such as centering. Centering is a wonderful way for a group of women to get all of their health care at one time and to build a rapport with people who are in the same position that they are in their pregnancy, ask questions of each other, learn from each other, and be led by one midwife. And then the absolute gold standard would be to see them during their pregnancy, transfer them over to Healthy Start, let them be followed for 2 years after that, and then, help transition them into that later phase in life. Any questions? Oh, no questions. Sorry. Thank you so much for this.
Hi, good afternoon. As mentioned earlier, I'm Daryl Thompson with the College of Nursing. I have the pleasure of telling you about two of our federally funded grants that we have in the College of Nursing to hopefully help increase the shortage of primary providers in the state. The first, Mr. Richards kind of alluded to it when he was giving his talk about Medical Associates Plus. It's the Rural Health Immersion within Primary Care Partnerships for APRN Academic and Clinical Training, or the IMPACT grant. We were just funded for this July 17th, and the funding goes through June 30th of 2019. It's a little over $1.2 million over 2 years. We were very fortunate. This was born out of the idea that in our medically underserved and in our rural areas, we have a shortage of primary providers, including APRNs. And one problem we have as educators, we can accept many more students, but if we can't place them in clinical to do training, then we're kind of at a backlog. So we can't relieve that shortage better if we can't get them into these training sites or clinical sites. But with these medically underserved in rural areas, this lack of primary care has been eloquently communicated, leads to greater health disparities and unhealthy behaviors. Untreated hypertension over long-term and untreated can lead to heart disease and stroke, which our state has a big problem or high numbers of people with heart disease and strokes. But we have partnered with 3 FQHCs, MedLink, which Mr. Richards explained to you about them, community health systems. They are in some of our adjacent areas, but they're all the way down into South Georgia also, even down as far as Telfair County. And MedLink Georgia, they're primarily in northeastern Georgia. We have students all over the state, but our Athens campus too, we have a fair number of students in that area. But a large part of this grant provides students funding to travel to these rural areas. So that is a big incentive for the students to do it, to participate. So they get this practice in providing care for taking care of these very sick patients, as Dr. Richards said, with the bag of 30 medicines at the appointment. But the mission is to expand high-quality primary care services in rural and underserved Georgia through a formal academic practice partnership to educate the doctorally prepared family nurse practitioners with the knowledge, skills, and commitment to provide comprehensive primary care to vulnerable populations. And we want to produce premier DNP, FNP graduates with the knowledge and skills to provide the care for these medically underserved populations. But this is led by an advisory board. It's made up of our faculty, representatives, and practitioners from each of the clinical sites. And we're expected to support 30 students over the lifetime of this grant. So that's potentially 30 more family nurse practitioners in the pipeline to go into these rural settings. But with this academic practice partnership, we also are wanting to incorporate more of this rural health care and underserved populations to our curriculum, so that they'll get more of that, not only in the clinical setting, but in the classroom also. And we will use these preceptors in these sites as the content experts to help us do this. So the overall outcome would be the education of FNPs who are prepared to work at full scope of practice and provide quality, cost-effective care. And we also use telehealth. You heard Mr. Richards say they're incorporating MedLink also heavily uses telehealth. and community health systems is planning on incorporating. So we're hoping to increase access that way. Our second grant is the Behavioral Health Workforce Education and Training Program, or BOET. This is also a HRSA-funded study. It is a little over $1.6 million over 4 years. This is a very unique grant in that it is to provide behavioral health care in the primary care setting, especially there again in these medically underserved and rural areas where they're doing good just to have one access to a health care provider, much less behavioral health. But it's interdisciplinary. It's with our psychiatric mental health nurse practitioner program, the psychiatric residents with the School of Medicine, and with the master's level psychology counseling students here at Augusta University. It's going to actually, there again, the students are receiving a stipend, and this is actually paying part of the psychiatric resident's salary for the year, for at least 1 year. But the mission is to provide mental health care to rural, underserved, and vulnerable populations within Georgia by easing access and offering these services in the primary setting, and also using the interdisciplinary approach. And so the vision is to produce psychiatrists, psychiatric mental health nurse practitioners, and licensed counselors who are flexible to work in the primary or the secondary care setting and have the knowledge to work collaboratively to serve rural and medically underserved and vulnerable populations. And this project is going to use a collaborative care model too, where in concert with the primary care provider or in conjunction, we're going to introduce the care and even consult. And telemed and telepsychiatry is going to be a big part of this. But through this, we want to increase the number of professionals to provide behavioral health care in these rural and underserved areas.
Good afternoon, Senator Unterman and distinguished panel. Thank you for this opportunity to talk a little bit about the work that we at Augusta University have been doing with Georgia Watch, an organization that I know you're familiar with. Dr. Beth Stevens at Georgia Watch is the project director for a PCORI grant, and we at the College of Nursing are her academic research partner. We've gone through the first 2 tiers of this pipeline to proposal award, and we've gone around, much like you do with your town halls, we've gone around creating different spaces to talk with a large number of people in the rural communities and to ask them, what's important to you about your care? What would you like us to study to see how maybe we can make it better? The project really is designed around rural access to care and, of course, how nurse practitioners can make that better. We've talked about everything from birth through death, about all kinds of possible questions. Patients and stakeholders have helped us to generate a lot of questions. Now we're starting Tier 3, where you've gone down to 2 questions that we're going to decide between and develop a proposal in the next tier. Here you see on the slide the top 2 questions. These are questions, again, from the patients and stakeholders. What rural community dwellers say is important to them. I was really surprised about the first one because I thought everybody would be wanting to study what's happening to them personally. But what the folks said is that, you know, we've seen, we did have people report to us about one model where practitioners are doing a great job where they go into schools and have school-based health clinics and with children who otherwise just couldn't learn at all. But with the use of telepsychiatry, they give them some behavioral health counseling and needs right there at their school. So it decreases the problem with access to care. And they're seeing that it's making a big difference in the children being able to learn. The patients we talked about with said, you know, we think that this will have kind of the greatest impact on the community, because if these little kids can get straightened around, they'll really become good members of the community and productive. The other top question that one is competing with is about studying more about a nurse practitioner-run clinic. One of the places we go for our patient roundtables is at Mercy Medical Clinic. It's a free clinic in Lyons, Georgia. And I've talked with a lot of patients there. A nurse practitioner does run that clinic, and of course, they have a lot of consultants, and they're hooked up with the Mercy Medical Clinic. But in talking with patients and trying to ask more questions, drilling down about what's really important to you, you know, like one of them said finally, you know, what's really important is we want to be treated like a whole person. We go to the emergency department because it's all we have, and like after, whether it's trauma, a broken arm, or whether it's some flare-up of their chronic disease, they patch us up and send us home. We don't know what's wrong with us. We don't know how to take care of ourselves. They don't have time or the interest in talking to us, and so we don't know what to do when we get home. They say they want care that takes care, of course, them physically, educates them about how to help themselves, wants to take care of their spiritual needs as well as their financial needs. They say we can help ourselves, but we need some help to do that. So, of course, they're talking about more what nurses are schooled to do and what nurse practitioners do. So we do have this one clinic in Lyons that is nurse practitioner run, and we look at studying more clinics like that and comparing them to a traditional model of care. Both of these competing questions would be using telehealth services. So these are some of the concerns raised by the rural communities we've been talking with. So as we go with our future opportunities, I've put a few thoughts here on the slide. We will be developing a proposal and putting that forward. But you know, it's a great idea, and whenever you get a chance to encourage this, I would, about nonprofit organizations and academic institutions partnering with each other for the benefit of the community. We found how productive that can be. And with me working a lot with Georgia Watch, it's really helped us to find more patients and find more stakeholders and build this great collaborative community that we now have. The second point I have here is really about the importance of, in any type of project that you have, research or some other type of service project, the importance of involving the patients, those who will be affected by what you're doing early, and sustaining that involvement throughout. And that's what we're doing in our research. And the last thing is, don't want to forget to mention the importance of involving students in what we're doing. And we have involved doctoral students in our project. It's a great learning experience for them. Thank you.
Thank you for your attention. And lastly, it's my pleasure to talk to you about a proposed training thing that we are trying to put together for nurse practitioners as emergency providers for rural hospitals in Georgia. And as both Dr. O'Neill and Congressman Dr. Mark Newton know, as trained in emergency care, rural hospitals in Georgia really struggle to provide urgent and emergent care to the citizens they serve. Many providers lack training in urgent and emergent care, and access to effective consultation with those who do is inadequate. Few providers are trained also in emergency care. Those who are trained in emergency care don't choose to stay in the rural setting. So these are really issues that we struggle to take care of. So this collaborative training program is one way we think to address this. This is an interprofessional partnership between the AU College of Nursing, my emergency medicine colleagues at the Medical College of Georgia, and our AU Center for Rural Health. This is proposal would train postgraduate, doctorally prepared nurse practitioners training together with emergency medicine residents. And then they would have additional specialty training in the use and application of telehealth, telemed technology as a consultative tool in the rural setting. So it's kind of neat because the individuals, the nurse practitioners would be here and train together with our emergency medicine physicians so that that trust and that relationship is built. And then they would go into the rural hospital and they would then they would train on the telehealth technology to be able to do those consultations in a way that they are competent with and that they feel that they can provide that rural care for. So we would have additional specialty training in the use and the application of the telehealth technology. So we're seeking funding for this because the benefits and the cost that NPEP-trained nurse practitioners would contract to stay in the rural emergency care setting for 2 years. So that would kind of take care of the problem that those providers leave the rural setting after they're trained. Then we would have the estimated startup funding for one pilot site is approximately $260,000, and we have based that on the cost that it would take for the faculty to do the training, the cost that it would take to have the equipment in the setting, and the tuition for the training. The estimated cost savings, however, is approximately $500,000 annually based on the differences between the nurse practitioner salary and the MD salary, because these physicians are currently in these rural settings in some places. We estimate that it would be a self-sustaining program by year 3, because then as the nurse practitioners move into the setting and the cost savings are there, the rural hospitals participate in helping with this training, we believe that it would be self-sustaining at that point. So that's my program, and in summary, for the panelists and from the college that we have talked to you today, Augusta University, I hope you can tell, is committed to APRN education, research, and service to deliver health care for underserved populations. We are out in the community doing that. We're developing these programs that we have had funded and are seeking funding for to continue to do that. We are leading numerous initiatives that include interprofessional and community partnerships, because without each other, we can't do the things that we do. And we're focused on telehealth as Georgia's new healthcare frontier, and on educating and participating with you, our legislators and other policymakers, about ways to overcome barriers to APRN practice in Georgia. And so with that, I thank you very much for your attention, and I invite questions to our panel. Thank you.
Do we have any questions for the panel? Y'all want to just step up to the mic and we can ask specific questions? Commissioner O'Neill, I keep calling him Dr. O'Neill. Commissioner O'Neill was talking about the emergency medical EMTs and their collaboration. Would there be a way to insert them into this proposal? I feel like I'm on Shark Tank. And how many slots were you proposing for that amount?
Yeah. Thank you, Senator Unterman. I think there could be. I was involved with Dr. O'Neill in my master's training for emergency and trauma care, and so I got to ride with the emergency care providers in DeKalb County and worked with them. And I've worked with these individuals that I'm partnering with, Dr. Richard Schwartz and Dr. Matt Lyon, and both of whom, as you might know, are heavily involved in pre-hospital emergency care. So whoever could give us funding, we would certainly bring that into the mix. As you know, it's a team effort from pre-hospital all the way through emergency care in South Georgia. Rural Georgia is a part in trauma care that really needs attention. So that is definitely something I think that we could bring into the mix easily, because we have these training programs, and in fact, we've modeled this training program after a training program that's already in place, so it wouldn't be too hard. And you might know Dr. Schwartz runs the pre-hospital care training also, so it'd be easy to bring that through. Thank you.
Any other questions? Thank you so much. I appreciate it.
I did have one.
Sorry, we don't have a button to push. I'm used to a button at the Capitol. And you push the button and it lights up.
So we've heard a lot about reaching out to the community, and the question is, do we have enough APRNs out there? I know that's a silly question, but and I think probably everybody would be involved in saying this, but as hard as we're all working, we hear from Emory, we hear from all the other schools, we're all just maxing out our capacity based on our faculty and our clinical sites. So I'm just wondering if anybody had anything to offer. I mean, it is good to bring in these HRSA grants. Those are just critical to be able to bump it up. Then they go away, and then you struggle to keep it up, and you try to keep it, whatever advantage you got. But did you have any other parting words about just getting those numbers up so we can prepare these numbers for mental health and for primary care? Dr. Inglet was talking about how she hardly has any APRNs to refer to, and she has much need for that. So just is there any parting word about just getting the volume up here in Georgia?
I can certainly speak to the need for APRNs, and the opportunities, I think, in the rural setting are just limitless. The problem with nursing in general right now is we're all phasing out. We're all at the end of our careers, and the new ones coming in are not still going to be able to meet the demand of the healthcare system. And when more and more people move into the healthcare system, as they did with the Affordable Care Act, we were at a detriment to start with, and it's even larger now. And it will continue to grow until we're able to produce the number of advanced practice nurses to meet that. And to do that, we've got to find clinical sites, clinical faculty who are doctorally prepared. It's a cycle, and one domino throws everything out of whack. And in the rural settings, especially, I can't imagine what could happen if you had, just 5 APRNs to move out. What could you do? What could you envision? It's almost a limitless system because you can, the continuity. If, we all know that the advanced practice RN is trained to a very high level, and they know when to pass off to a physician, when to step back and say, this is past my wheelhouse, I can't handle it, and I need to call in a physician and get that help that we need there. But it's from a training standpoint, we've got to increase the absolute numbers just to maintain, and we've got to grow the numbers to catch up.
And I think by specialty, especially psych, mental health nurse practitioners, everywhere I go, I was just at a meeting with our Serenity Health Care, which is our local mental health center, and they have a shortage of psychiatrists and psych mental health nurse practitioners. So I think entire statewide, we do have a shortage with psych mental health. And then with primary care, with the family nurse practitioner in rural areas, the very rural areas, I do think we have a shortage.
I'll say, I think the more opportunities that we can create, especially for emergency individual advanced care providers in the rural settings, the more may stay there, because I can speak for myself, trained in emergency care and trauma care, and then I had clinical experiences in the rural setting. There was no place at the time for me to stay as an advanced care provider. With this program that we're proposing, that matches the two. Individuals who love their passion with emergency and trauma care might have a way to stay in the rural settings that need them the most with this kind of proposal. And so I hope you will consider ways in which we might fund that, and ways in which we can increase overall advanced practice in rural settings. Thank you.
Okay, thank you very much. We appreciate y'all's time. Last on the agenda is Catherine Clary, Director. Oh my gosh, there's no way. Catherine Cleary. Also, I wanted to announce, I know some people have got to leave, the next meeting of this committee is going to be November 6th. It'll be at the Capitol at 10 a.m. And that'll be next to the last meeting. The last meeting will be in December, and that's the wrap-up meeting where we will meet to come up with our conclusions and report to the General Assembly. Thank you. Need to go quick.
I will be quick. Luckily, I had the nursing group ahead of me to go through a lot of their projects.
Good.
And so I'm Catherine Clary. I'm the director for the Center for Rural Health Support and Study here at Augusta University. And as the Center for Rural Health, a lot of my job is just trying to garner all of the different projects that we have going on throughout the university, the medical system, and our undergraduate programs, and find out different ways that we can help rural providers in the community. With that, a lot of my focus is on innovation and education, because we want to have new ideas, and then also we have education. Obviously, we're the medical school of Georgia, but we education, I think, doesn't have to be a formal education, but also sometimes a peer-to-peer collaboration that can also teach people in the rural communities. We all know the challenges that are facing our rural providers, and our big focus is keeping that patient closer to home so that the patient has the benefit of family and friends close by. And then that also helps the rural hospitals and the tertiary centers by moving those patients. Back in 2015, President Brooks Keel got together a rural hospital task force, and Dr. Canto led the task force in coming up with issues that rural Georgians were dealing with, and then recommended actions for dealing with that. Today, I'm just focusing mostly on the first, which is orientation and ongoing education of CEOs and board members. So why do we need to focus on board education? A lot of times the boards outlast the CEOs and other administrators. I think in rural hospitals, maybe it's about an average of 3 years for CEOs and administrators. So the board members are those community members who have been in the town for a long time. They're the bankers, the attorneys, the kind of pillars of the community. And so they are oftentimes around a lot longer than some of the physicians or administrators. And so we want to realize that the healthcare landscape is changing. We all know that. And so learning is crucial to keep up with those changes. Part of that with boards is teaching about population health and different insurance changes. Also, the decisions to affiliate or partner with other entities, whether that be other hospitals, management groups, FQHCs, and different ways that we can work together. Also, that's researching and adopting new staffing models, just like what we were talking about with the APRNs, using those more than physicians in the community. And then also looking at board succession management. We want to see how many board members should we have, should there be term limits, and how we get the right people in on the boards. So we do think that education is key for these board members, and we want to have timely education, but we want it to be to the point. We don't need to have excessive theory on how to run a board, but we want more of the day-to-day. How can we stay up to date on challenges and learn those trends? And then also sharing best practices among rural hospitals. We started that back in April. We first had a board education meeting with the combined boards of Coffee Regional and Jeff Davis. Coffee Regional is, by legislative standards, not a rural hospital, but most people would agree that it's a rural community. They're a little bit larger than Jeff Davis, but they had been working together on some OBGYN projects. So we got them together for a day of board education. And we had a keynote speaker from outside of our facility, but then we were able to have people from all over the institution talk about population health, telemedicine, clinical integration, organizational effectiveness, and other insurance topics. The education was well received. We got great feedback from both of those boards, but one of the things that we saw was that a lot of the people were saying part of the best part of the day was learning from peers and being able to see what's working at one hospital and how that could work at another facility. So with that, we took that information, and for our next event, which is coming up November 1st, we are having a CEO and board chair symposium. We're holding this down in Albany because we wanted to make sure people knew that we had students in Albany and also have a better location for people in West and Southwest Georgia that may not be coming over to Augusta very often. So our symposium is under the gun, sharing successes and failures to navigate towards sustainability in rural hospitals. And I wanted to focus on the failure part because I think we all know that a lot of times the best learning experiences are from failures, but we also would like to learn from other people's mistakes and perhaps not make our own. So we have a great agenda. We have CEOs from all over Georgia. We have someone from Peach County. We have Miller County, Jeff Davis. And then we have a keynote speaker, Tim Putnam, who is the CEO of Margaret Mary Health in Indiana. And he will be coming to give a broad overview. He's very involved in the National Rural Health Association, and he's also bringing a data analyst with him who will kind of look at some of the data that we have here in Georgia and make some recommendations and analyses. So that's coming up. We're very excited about that. And as I said, our goal is to bring education and innovation to rural areas and to use all of the resources we have as a university to do so. And with that being said, I'm really trying to go out into the communities and ask what they need or ask what they feel their needs are instead of coming and explaining what we think they should do or what their best bet would be, or we've learned this from somewhere else. So I think a lot of it is kind of breaking down that ivory tower mentality and rolling up our sleeves and getting dirty and getting out there with the rural providers and trying to figure out what it is that they need. That's it. Thank you.
Can I ask you a question? One of the things I've heard from all my hearings this summer is that there's a need to educate the people that are appointed to the boards of hospitals.
Yes.
That, a lot of times they're political appointments, and, I've made my fair share of political appointments. But when you put the used car dealer on the hospital board, that hospital that has a $35 million deficit, and you've got to get your head out of the water in healthcare economics, and they have no clue.
Yes.
Have y'all discussed that?
Absolutely. That is something that we've talked with CEOs and boards about the need for that healthcare side of finance education. And I think that there are great things about having a well-rounded board and having people from different areas, but there is that learning curve. I did not come from a healthcare background when I started at AU 3 years ago, and it's just, if anyone who is in healthcare knows, it's a completely different animal as far as running a business and running a hospital. So I think that this is where we have opportunity to motivate these boards, teach the boards, and as they give them more sustainable, concrete steps that they can take.
So you don't have a requirement of how many, continuing education credits they need to have?
No, not in Georgia.
There's nothing mandated?
There's nothing mandated in Georgia.
Is there in other states?
There are in other states.
Like what states?
I believe that I just read maybe Iowa has through their, and I will double check to make sure it is Iowa, but through their health associate, like our Georgia Hospital Association, they have requirements for new members of boards and also ongoing education for boards.
So what outside agency could facilitate that with, there's 3 hospital boards in the state of Georgia. What outside state agency, maybe the commissioner knows, could facilitate that?
Well, she was referring to the association. That's who the department works with on a lot of continuing education for different parts, specifically through healthcare regulations. And public health department, public health for emergency preparedness and coalitions for education on emergency preparedness. Those might be 2 avenues that we can see for more education.
I know that's a proposal going to be coming up in January to mandate that these boards have some type of education instead of just appointing them to a board.
Absolutely. And I think some of the boards here in Georgia are proactive. I know that one that I was just talking with it's part of the Phoebe group at one of the rural hospitals, but she was just saying she couldn't come to the symposium we were having because she was going with her new board members for a training. So there are some hospitals doing that, but I think it would be highly recommended that it is a requirement.
Well, it would help if it were the same across the state.
Absolutely.
So that one wasn't better, one wasn't lacking, and there was consistency.
I agree.
Okay, thank you.
Thank you.
All right, we have 3 left, and I think I'm going to ask Denise Cornegie, I'm going to ask you to present at the next meeting because I really want to get into that preceptorship. Oh, is she here? Where are you? Will you be able to come November 6th? I'm not sure what day of the week that is.
It's a Monday.
Is it 10 o'clock at the Capitol? Okay. You can't drive? Yeah, I knew that. Well, I want to spend some extra time, and I'm going to have Georgia watch at that meeting. So I don't want to cut you short, and I want to be able to ask questions. And I think it would just be better if we had more time. Good luck. You already had the surgery? God bless you. Doing okay? Good, good. We appreciate it. Okay. Dr. Suzanne Stabler.
Thank you, Madam Chair, and the members of this committee. So I was tasked to give you a brief overview of basically APRN regulation on the national front. So I was the speaker responsible for the thickness of your packet that you got today because I usually spend 2 or 3 hours doing this talk, so 15 minutes was a stretch for me. So you have lots of supplemental reading when you can't go to sleep tonight. So the consensus model for APRN regulation is something that started back in 2004, 2005, where on a national level, the stakeholders related to APRNs, the licensure groups, so the National Council of State Boards of Nursing, those related to education, certification, accreditation, as well as practice groups, got together and designed a consensus model so that we could begin to move as a profession to standardization in these 4 areas: licensure, accreditation, certification, and education. At that time, every state did something a little bit different in all of these areas. And so in 2008, the model, and which is in your packet, you have a thick little bundle there, was actually adopted by the Delegate Assembly of the National Council of State Boards of Nursing. And so all 50 states, as well as DC and Puerto Rico, have endorsed that model. And we are slowly but surely getting to the point where all of the states have adopted all aspects of that model. So you may hear in the APRN world the acronym of LACE, and that's what the acronym stands for. So it's, again, the 4 areas of APRN regulation. So in a nutshell, this is what the model looks like. So we have 4 different roles of advanced practice nurses in the United States. We have the nurse anesthetist, the nurse midwife, the clinical nurse specialist, and the nurse practitioner. And unlike our colleagues in medicine, APRNs are really educated at a population perspective. We aren't educated and trained based on a body system. And so What is most complex, though, is for the nurse practitioner, because the nurse practitioner, actually, we have programs in all of these areas. And then for adult gerontology and pediatrics, you choose to focus either in the acute care setting, so what happens inside a hospital related to surgical critical care, or you can choose to focus in that primary care realm where you are dealing with health promotion, wellness, prevention, as well as episodic illness. So what is currently happening nationally in these 4 areas? So again, L stands for licensure, and this area of regulation is actually overseen by the National Council of State Boards of Nursing. So here in Georgia, I've listed the 6 areas in the consensus model that relate to licensure. And so the 2 designated here in white are the 2 that Georgia has yet to adopt out of the consensus model items. And that includes a separate license as an APRN. So currently APRNs we're all licensed as RNs, and then we are given special approval by the Board of Nursing to practice in an advanced role. And then we all have to maintain national certification. That is a requirement of licensure for APRNs. And then the last item that we have not adopted would be full practice and prescriptive authority. So I show this state, this is specific to nurse practitioners. So when you look at the breakdown of APRNs here in Georgia, probably about 65 to 70% of the APRNs here in Georgia are some sort of nurse practitioner. And so I like showing this map because if you were to overlay some of the maps that Dr. Karen Minyard from the Georgia Health Policy Center presented at our last meeting looking at health outcomes like infant mortality or maternal mortality, you would see very similar maps because the states in red and yellow have the more restrictive practice environment for APRNs. And those states also tend to have poorer health outcomes for their citizens, especially if they have large rural populations. And so if we were going to talk about Georgia specifically, I would have to point out that Georgia is the most restrictive state for APRN practice in the United States. So while we as educators attempt to educate all of these people, the issue is they're not staying in Georgia because it's so difficult to practice here. So under accreditation, so we have several different accrediting bodies for APRNs based on the program of study. So aCNM and CCNE are the accrediting bodies for clinical nurse specialist and nurse practitioner programs. aCME is the accrediting body for nurse midwifery education, and then COA is the accreditor for nurse anesthesia programs. In your packet, you will see a crosswalk, a chart outlining the different areas of accreditation standards for all of these organizations, as well as graduate medical education. And you can see that there are many similarities in looking at programs and standardization of what those programs look like. As was mentioned earlier, I would like to point out that nurse anesthesia is the first APRN role to decide that the doctorate of nursing practice will be the minimum standard for entry into practice, and that transition will occur by 2022. Certification, so we all levels of APRNs in Georgia have to be board certified in order to be licensed and maintain our license. And that is pretty much the state of affairs across the United States. There are still a couple of states that do not require board certification for licensure. The other thing that is really important to point out is we have to maintain our certification, and all of the certification boards for APRNs have what is called a continuing competency program to make sure that with the care we are providing is competent and up to date. And so we have to be able to demonstrate to our certification body that we are maintaining those standards through continuing education, involvement in quality and patient safety initiatives, as well as practice. And then last but not least, education. And so all APRNs are educated to provide across the continuum care in the wellness, illness continuum. But how that is applied will look a little bit different based on the role and the population to be served. So there are enhancements of national core competencies for both the core roles, so the 4 roles of APRNs as well as the population, and then much more stringent criteria for the evaluation of curriculum. And so some of the other things that were new with the APRN consensus model for APRN education included making sure that graduates were prepared for their national certification exams, as well as making sure that new programs couldn't just pop up and admit students, that they had to go through almost like a pre-accreditation process to make sure they were meeting educational standards from the get-go. And that includes even postgraduate certificates. So for instance, I am a neonatal nurse practitioner, and if I wanted to go back and also take care of older pediatric patients, I wouldn't need another degree, but I would need additional education and training in primary care pediatrics. And so that would be given as a postgraduate certificate. So now those programs also have to go through the accreditation process. So I was also asked to talk a little bit about APRN education standards. And we've heard earlier from Dr. Downs about APRN education being at the graduate level, and that can be either at the master's degree level or the doctoral degree level. We've talked a little bit about the doctorate of nursing practice degree. There are some universities such as Emory that also offer APRN training as part of a PhD program. And so those are nurse scientists as well as advanced practice nurses. Again, all new programs must be reviewed prior to admitting students, and all programs must hold national accreditation, which is very similar to our physician colleagues. The APRN curriculum builds on pre-licensure nursing curriculum. So unlike our medical students who enter and really don't have any clinical background, the curriculum is actually almost like building blocks on the baccalaureate nursing foundation. And our programs are based on competency outcomes. And so we talk a lot about clinical hours and how many clinical hours is in this program versus that program. It really, nationally, there is a minimum threshold of clinical hours, but students have to be able to meet those competencies. And it doesn't really matter how many clinical hours it takes for them to get there. So it's not just about clinical hours in our programs. And so you will see this chart also in your handouts, looking again at the program standards for ACGME, as well as I just chose nurse practitioners again because nurse practitioners are the largest majority of APRNs here in Georgia. And you can see the education standards for accreditation are very similar across both sets of educational standards. So one of the other big issues nationally that we are looking at currently is really about scope of practice and practice alignment. And so what I tell students and people who I talk to in this realm is our scope of practice is really about our APRN education and certification. And there can be laws at the state level that impact our ability to practice the way we were educated and certified, but a law can't expand our scope because we would need additional education and certification to do something different outside of our original education. And so it's really important that we understand that our practice has to align with our education program as well as our certification. I'll take any questions.
Dr. Stabler, I have a question. Thank you for that excellent overview. Do you know how NP certification compares to physician certification requirements?
So I would say in most states it's relatively synonymous. In Georgia, in the 2017 legislative session, House Bill 165 passed, both chambers, and was signed into law by the governor. And that actually now allows physicians to not maintain their board certification as a criteria for relicensure, for payer enrollment, malpractice, or employment. So at this point, APRNs actually have a higher standard when it comes to maintaining certification and our continuing competency than our physician colleagues.
Yes, I know that the PA colleagues as well do not have to maintain certification for licensure in the state of Georgia.
Okay, there you go. I didn't know that. Yes, ma'am.
I could say something about the overreaching requirements of medical recertification, but I won't go there. But
okay,
I was not familiar with what you were saying about the practice of advanced practice nurses in Georgia is the most restrictive. Can you explain to me what that is?
So certainly, there's a couple of things. We're the only state that does not allow APRNs to order radiologic tests. And so that is probably the biggest thing that puts us there. And we're one of only a handful of states that limits the number of APRNs that can be attached to a physician in a practice. And so that gives us that designation. Does that make sense?
So it's 4 to 1 physician. Is that the criteria?
Actually, it was just expanded this last session to 1 to 8, but no more than 4 can be practicing at any one time. So, for instance, if you were in a large practice, if you in Clark County, Clay County, had 8 APRNs, only 4 of them could be in the clinic at any one time.
Okay.
Okay. But you could still oversee 8, but only 4 can be actually providing patient care at any one time.
Okay.
And there's only one reason why that bill passed and became law, and that was because the Georgia Retail Association wanted that law, and that's for the minute clinics.
Right, the urgent care clinic.
And that was because the CVS, the Walgreens of the world could not schedule 4 with one physician at one time because one might be out on sick leave, one might be pregnant, So we increased it to 8. But the only reason it passed was because it was sponsored by the Retail Association.
Yeah.
I actually carried that bill. Know it intimately. Okay, I have one question. We're going to finish up.
Okay.
So what is the entry level? Because I thought it was intriguing. The gentleman from the FQHC said that an APRN can have 3,600 visits a year annually and a doctor 4,200, but the APRN is half the cost of the same amount of care. So what is the cost of a seasoned, has a history, several years in practice APRN that goes to a clinic to work? What is the salary cost?
I don't know that I'm the correct person to answer that question. I can certainly talk about acute care nurse practitioners in the hospital because
No, he was talking about doctor visits. doctor's
Right.
offices.
So are you asking me like salary
Yes.
costs? Yes.
Yes.
So new graduate primary care nurse practitioners come out in the Southeast somewhere in the 80s.
80,000?
Yes. The Southeast is traditionally the lowest region in the U.S. when it comes to compensation of nurses globally, and that also includes APRNs. Well,
So
I think part of
80,000 is no experience,
yes,
except clinical hours and training.
yes,
Okay.
and then
we'll
you
do
would
the
kind of work up
research.
from there.
Okay, we'll do the research. So if you get into like an intensive care unit or a trauma nurse
So
practitioner,
I can tell you neonatal nurse practitioners fresh out of school in the Southeast are starting somewhere in the low 90s, 92 to 94,000. I just published the workforce survey for the neonatal NPs.
neonatal NP is how much now?
92 to 94.
In Georgia or?
That's the Southeast region.
Southeast, okay. And that's no
experience as an NP.
Experience.
Mm-hmm.
Okay, so what if you had 5 years experience?
So you would probably be about 105. And for someone like me, if I were to be in full-time practice, I would probably be somewhere in the 130s.
Okay. Well, that just, I'm not trying to be personal, I'm just trying to figure out.
No, I'm just,
when he
I don't
came up
practice
with that.
full-time, so it's okay.
So, Commissioner O'Neill, I know I worked on the nurse's salary in the public health department. Obviously, it's much lower for a nurse practitioner. Do you know that amount for the public health?
I do not, but I would, my vague recollection is that it would be about 3/4
That's what I thought.
of that.
I was thinking around 60,000.
Yeah.
Yeah, because, you know, I did that bill. And so one of the people that testified, the suggestion was in Burke County for an entry-level APRN in Burke County. So we could put a line item in the budget to put APRNs in more public health departments. Is that correct? And if we did the patient-centering model for prenatal care, you could specifically say that, right? Okay. That's what I needed to know. Thank you.
You're welcome.
We appreciate it.
Senator Unterman, if I could just make a couple clarifications on those comparisons, though. The FQHC model provides an extraordinary amount of administrative time for their doctors, like a day and a half a week, and rather low performance goals, honestly. I mean, I see 73,000 compared to the 40, and I think most private would see more than that. Also, the reimbursement, they would get more for an insurance visit than the mid-level resident nurse practitioner would.
Yeah, I've got it written down that it was FQHC. Yeah, I'm very familiar. Okay. Thank you.
Good afternoon.
Good afternoon. You're the last on the list.
I am the last person standing between you and a commute home. Thank you all for letting me be here today, and I hope that we can spend this last few minutes. I'm thrilled to tell you this story, which I feel is a very compelling story of an advanced practice nursing-led clinic, the Integrated Memory Care Clinic. I am also an alum of Medical College of Georgia. That's what it was called 10 years ago when I finished my Doctor of Nursing practice here. And so this past fall, I got 3 notifications that I was old. I have a teenage daughter in high school now. I went straight to progressive lenses, and the NIH notified me that I'm no longer considered a new investigator because it's been 10 years since I finished my doctorate. It's not a problem for me, though. I love old people. They are the reason I became a nurse. So I want to talk to you today about the care of older Georgians and one of our most vulnerable pockets of that population, people living with Alzheimer's and related dementias. So I'm telling the story of the Emory Integrated Memory Care Clinic. It's an advanced practice nurse-led clinic. We are incubated and embedded within cognitive neurology in the Emory Brain Health Center at Executive Park off of the North Druid Hills exit of I-85. We have clinical backup and support from our colleagues in cognitive neurology, in geriatric medicine, and in the palliative care center. I myself am a nurse practitioner board certified in gerontology, which you did not see on that population model a moment ago. That's no longer another reason I'm old, and also an adult gerontology primary care nurse practitioner. This model is new. We invented it here in Georgia, and we did so with the input of family caregivers who are currently or previously taking care of someone living with dementia. 2 years in, we were 2 years old as of this May, we're now a nationally recognized level 3, the highest level of recognition, patient-centered medical home. We provide primary care for this defined population, people living with dementia. We're designed to replace someone's previous primary care provider, and we consider ourselves a one-stop shop. One of our family caregivers referred to us as the Walmart of clinics. We chose not to be offended by that. What they mean is whether the person with dementia has a cold, maybe they need a vaccine, preventive care, they have a change in behavior, we treat all of those things. And we follow these 8 design principles, one-stop shopping being the first. We have very thoughtful utilization of services. So in this condition, all of our patients come to us with this diagnosis. Sometimes we get more specific about their diagnosis and the type of dementia, but the reality is they are all living with a progressive, degenerative terminal illness. And so we have very thoughtful and candid discussions about some of those difficult topics that come up. So when to utilize additional services such as specialists, when to continue participating in preventive care and screenings, and when it's appropriate to stop those. We connect our patients with services in the community that would not necessarily be considered health care, but are part of the aging service provider network. We work closely with the Georgia Alzheimer's Association, with the Area Agency on Aging, and for us, that's the Atlanta Regional Commission. We are very aggressive about some things, and that's specifically behavioral symptoms of dementia. One of the most distressing and challenging issues for caregivers, and an additional burden for the person living with dementia, and the most likely thing to send them to an institutional placement, such as a nursing home. We have 24/7 access. I've been the nurse practitioner on call over the past weekend. 24 hours a day, you call an after-hours line, you get in touch with a nurse practitioner. During the clinic today, the registered nurse and the patient services coordinator are answering the lines, and we return calls within the hour. We have a team of clinicians. I'll tell you a bit more about them, and we do quite a bit of intentional work to make sure that our team functions at the highest level. And at our core, we are driven by patients and families telling us what services to offer, how to be accessible, what we need to do differently, what we need to add, what we need to stop doing. So as I said, dementia and the other chronic conditions are managed exclusively by nurse practitioners. Patients who come to this clinic do not see a physician. We do practice in collaboration with geriatricians and neurologists who happen to be in the same space as us or are available by phone. And the nurse practitioners have specialization in dementia or geriatrics or palliative care as driven by our patient population. We also have a clinical social worker on our team. So I want to speak to you specifically about these 4 barriers that we're experiencing in this advanced practice nursing directed practice. Requirements for the collaborative practice agreement. As Dr. Stabler mentioned, some of our inability to order things like radiologic testing and full scope prescribing, and generally a lack of recognition as someone's primary care provider. Collaborative practice agreements are sort of a challenging thing. Healthcare professionals practice collaboratively. It's part of our competency. But only advanced practice nurses are required to sign a legally binding document promising that we will collaborate. It creates sort of a challenge. We have this arbitrary number, this 10% of charts to review. And so rather than considering the complexity of the case and making sure that I bring those to my colleagues who are either in geriatrics, or if it's a neurologic problem, to the neurologist, or if it's around advanced care planning that's gotten sticky with our palliative care team, I'm following a 10% guideline rather than letting the complexity of the case lead to the decision to collaborate or to reach out for a shared visit. For us, in our one site right now, we have to be a break-even model. That's part of testing this model. It has to pay for itself. And so what we're finding is, what is the sweet spot in terms of how many patients we can enroll at our steady state and still not lose money? And so we have found that we probably need about 6 nurse practitioners at our one site to manage the patient population that we think is appropriate. It would not add additional office staff time for us. But that means I have to find another physician to do a collaborative practice agreement because we all need to be there in clinic at any given time. The radiologic testing piece. Now, our patients are supposed to come to us with a diagnosis of Alzheimer's or related dementia, but the reality is they don't necessarily get what I would call a gold standard diagnostic workup from their community practice where they're coming to us from. Sometimes they've got a label of memory loss. Sometimes a provider has assumed that it's Alzheimer's disease, but they haven't received gold standard, which includes neuropsychological testing and a structural imaging, which means an MRI or a CT scan for people who are appropriate. So when they arrive to us, sometimes we have to do a little bit of cleanup work to be specific about the type of dementia that this person is experiencing. It guides treatment decisions, and it certainly guides the planning for the family and helping them be prepared in terms of what to expect next. Now, this is an ironic one because I personally co-author the clinical practice guidelines written by the Alzheimer's Association, outlining that primary care providers should order an MRI or a CT scan, but I personally cannot order it for my patients without a physician's signature. As I said, dementia is a progressive and a terminal illness, and sometimes our patients along their course experience things like a hip fracture or need a joint replacement, or they've had an injury, and so for a short period of time they need Schedule II medications. Or as we're working them toward hospice and they're experiencing pain, we also cannot provide Schedule II medications in those cases. This is not something that comes up in with much frequency, but it is something that causes us to pause, interrupt someone else's visit if they're seeing one of the physicians in the practice so that we can get a signature for these prescriptions. In general, being a restricted practice environment, being known as the most restricted state, has this connotation, which is kind of a soft measure, but it comes up quite frequently for us because it creates this permissive environment to ignore that the nurse practitioner is someone's primary care provider. So if I do order one of these tests, often the results don't come back to me. If my patient visits the emergency department, I'm less likely to get those hospital discharge documents. Even though I'm calling emergency departments to say, as I did yesterday, I just want you to see this patient. Here's what the assisted living facility is asking for. Send them back if you can. I will see them in clinic tomorrow. But working that out has experienced quite a few barriers because of the fact that people recognize nurse practitioners in Georgia are not usually seen as licensed independent practitioners. And yet, we think we've been pretty successful. I'll share with you just a few of our outcomes from the last 2 years. Our patient population right now is around 250 active patients. Most of them have Alzheimer's disease. That's the 53%, which is about like the national numbers when you look at people with types of dementia. 11% still have mild cognitive impairment, but we do have other more, less common and very complicated cases like Lewy body frontotemporal. And as you can see, this 96% satisfied off to the side, that means that at this moment when this data was pulled, 4% of these individuals haven't completed that gold standard diagnostic workup that I was mentioning earlier. Most of our patients are in what we call the moderate stage, either early moderate or late moderate. That's about 75% of them. That's the stage of the disease in which someone's cognitive domains are almost universally impaired. So memory, sense of space and time, ability to plan and execute things that require a series of steps like cooking dinner, taking a shower, driving a car, are all impaired, but they're still mobile. So this is the time when people wander, they don't sleep well at night, and they have quite a few what are things that are known as behavioral and psychological symptoms of dementia. Generally, people refer to them as agitated, anxious. So this is sort of the peak of caregiver distress period, and that's when people most often come to us. This is our one, what I call overall measure of success, and this is somewhat complicated. I'll show you more clear evidence. And this is our ability to keep people living with dementia out of the emergency department and the hospital. These are ambulatory care sensitive admissions. These are things for which if you were being well managed in your primary care practice, you would not arrive in the hospital. And so when we began, and we get these measures month over month, when we began, our patient population was relatively low at 5%. We have kept them below 2% every month. And I got our numbers for yesterday, which is the previous month. We are at 0.9% right now in terms of ambulatory care sensitive admissions to the hospital among these folks. Nationally, people with dementia have a 15% ambulatory care sensitive admission rate, and we are at 0.9% at the moment. And that's with an increasing every month, the denominator goes up because we add more patients. And people seem to be very happy. We have the best patient experience of any clinic within the Brain Health Center and one of the top primary care practices across Emory Healthcare. These are some of our comments from last month. None of them are about me, so I felt comfortable sharing them. They love all of us. I want to also tie this to another initiative that our legislator has done very well in the last year. This is an article from the Georgia Council on Aging. One of the wins for older Georgia that they cite in this article was the $4 million appropriation to the Georgia Alzheimer's Project. This, of course, is with our colleagues at the Brain Health Center to create memory assessment centers in conjunction with other medical schools throughout the state. What we found in our integrated memory care clinic is being attached to what's essentially a memory assessment center at Emory. Many people, once they receive that diagnosis, the question is, now what? Now what do we do? How does this affect everything else? Dementia is one of those things that you call a dominant illness, meaning all of the other decisions about your health care go through the lens of the fact that this person has dementia. And so many of our patients come to us that way. What would prevent us from doing integrated memory care clinics near or around those memory assessment clinics, which, by the way, are an excellent first step, because the Alzheimer's Association nationally tells us people with Alzheimer's disease right now do not get a diagnosis, and if they're diagnosed, it's not disclosed to them. So overcoming that with the memory assessment centers is phenomenal. The next appropriate step is to have now the care of those people who are living with the diagnosis from people who really understand primary care in a dementia-sensitive lens. So the barriers are essentially the same. The collaborative practice agreements, limiting those numbers and creating that artificial barrier for the collaboration. The inability to order the radiologic testing, again, when things change or you're determining something, a new symptom. The full scope prescribing and the lack of recognition of advanced practice nurses as primary care providers. I can talk about other barriers universally, but in the consideration of time, I'll stop here.
You did an excellent job.
Thank you.
I think it really shows the collaboration that you can put forth. Is there any questions? Nope. Okay, thank you.
Thank you so much.
Okay, for the benefit of the committee, I know we'll put the preceptorship on the next meeting, and I have invited Georgia Watch to come and give their synopsis of their study that they did. Is there anyone else who would like invited to the next meeting? Anyone else? If you do, you can talk with Megan. Anything else for the good of the committee? Again, we appreciate Augusta University and their hospitality today, Chick-fil-A. We appreciate it. The nursing students were phenomenal. I hope they didn't have to take a test. They're probably going out to take another test. They were studying for a test here. But we appreciate all the presenters today. We stayed on time, and we appreciate it, and we will see you next month at the Capitol. Thank you very much. I like the timer. Yeah, I do too. Keeps us on topic. I like the timer.
Yeah, I need section APHA.
No. Usually I move one day a year.